Hi, thanks for joining us. I'm here in conversation with Grace Berman, LCSW, who is at our New York office. And today we're going to get to know who is in her practice, who she'd like to work with. So, for starters, Grace, I know you work with people across the lifespan. Who does that include?
Yeah, thanks, Allie. First of all, thanks so much for having this conversation. Yeah, so I treat primarily anxiety disorders and OCD across the lifespan. So I work with adults, but I also work with adolescents, kids, being able to get treatment early and start to see more of that change trajectory for them to be able to understand the way their brain works and have the tools to approach it effectively from a young age is really great. And I also do a lot of work with parents. So it's equipping parents with tools, not just specifically about anxiety disorders and OCD, but also behavioral disorders, ADHD, other types of challenging issues, particularly for parents of younger kids. So that there's more of an understanding of how to respond effectively to your child's behavior. And also, as kids get older, really how to facilitate more of that family communication.
Thank you. And speaking of kind of the topics that you work with, notably, I know we were kind of talking about OCD, and can you share a bit about what's interesting you, what you're looking for, what you'd like to offer?
Yeah. Well, I really love treating OCD because there's so many misconceptions about it. And it's one thing that's really unfortunate is a lot of people might not get the right kind of treatment right away. And if you're not trained as an OCD specialist, you can inadvertently exacerbate some OCD symptoms. So sometimes people come in feeling like therapy doesn't work for them or like their OCD is feeling really overwhelming. But there is actually a really great treatment for OCD, and it's called exposure and response prevention, or ERP. And when you can do this, it has a really high success rate and it ends up being something that's really helpful to people. So it's really gratifying being able to work with people with OCD and really see that progress and really help them because it can be such a debilitating disorder if it goes untreated. And it's also such a successful one to treat when you do get the right treatment. And there's a lot of misconceptions about it. A lot of people think of OCD as like hand washing or being really organized. But, those are some ways compulsions can show up. But there's also mental compulsions, or, subtypes of OCD that are, sort of less common or sort of more shameful to talk about, where people have kind of sexual obsessions or obsessions about harming themselves or others. And these can be really distressing to people. And it can be really scary to talk about them with the therapist. And so being able to be that person who really understands what's going on and how to support people is just like such a gratifying place to be. I would say recently, I've been doing more and more work in the space of relationship OCD and finding that to be a really satisfying area to work, in part because there's a real amount of kind of normative doubt or questioning or anxiety that comes up in relationships. And so helping people differentiate what might be kind of typical relationship concerns or more of like a clinical relationship anxiety, where their anxiety is getting in the way of their relationships, their romantic relationships in particular. And then where does it rise to the level of relationship OCD, where it's actually getting quite compulsive in the way that people are responding and kind of examining the relationship. It's such a spectrum. And so there is a level of relationship concern. Like it might not actually rise to that level of relationship OCD, but being able to support someone and really working through how they manage the uncertainty of committing to someone or being with someone and really all of the things that are unknown about how that's going to play out. And then really having that OCD lens of being able to recognize where is this worry getting to the point where it does qualify as more obsessive and compulsive. Because I think there's a lot that people can experience that's really not, they might not meet criteria for OCD. They might not think of themselves as someone who has OCD, but they might be experiencing a level of intolerance of uncertainty, which is like a hallmark of OCD, or obsessive distress related to their relationship. And they don't know how to work through that. And so sometimes using an OCD treatment lens, even if it's not quite at that clinical level, can be really helpful for people in working through those concerns.
That's really helpful to understand too, that it doesn't have to necessarily qualify as a diagnosis, but that framework is useful and that your discernment to help someone figure out where they are on that and how to work with it is really the key, regardless of how we want to label it.
Yeah, I mean, I think one area that I also like to talk about because I think it's more unknown and I think it's really important to bring more awareness to it. There's related to relationship OCD is a diagnosis called BDD by proxy or body dysmorphic disorder by proxy. And this can look like, relationship OCD is often an obsessive level of doubt about, is this the right person for me? Do they love me enough? Do I love them enough? Are there certain features about them that I'm obsessing about and can't really get over? And that's often what the content of the relationship OCD looks like. And then BDD by proxy is a related variant where it's specifically an individual who is experiencing unwanted, distressed obsessions about someone else's, their partner's appearance and a specific element of their appearance, but they also experiencing a very high degree of distress in the relationship as a result of this fixation point. So it can look quite similar to some of the relationship OCD type obsessions, but it is more specifically related to just that element of appearance. And it's something that I think a lot of individuals and even some clinicians are not aware of, but it can be, with the right treatment, something that people really get support with and can be destigmatized. I think that's a really important thing, is really thinking about how do we reduce shame people might be feeling for these obsessions. So often these intrusive thoughts are really unwanted and distressing. And so how do we reduce that secondary layer of shame so that they're not feeling that way?